Great. So I wanted to today talk to you about our ongoing project looking at the role of targeting the inflammatory compartment in BPH. And as was mentioned, my name is Renee Vickman. I am a research scientist at NorthShore University Health System in Evanston, Illinois. So thank you so much for having me. So we know that inflammatory cells accumulate as prostates enlarge, and in BPH, inflammatory cells make up a significant compartment of the cells that are there. So in large prostates, you can see both histologically and if we digest tissue and then do flow cytometry, we can see significant enrichment of inflammatory cells versus small prostates. So they do accumulate in the prostate as they enlarge. And we also know that in BPH patients, both the MTOPS and reduced clinical trials have shown that the patients with chronic inflammation, so the high grade group here, have a resistance to a therapeutic response. So over time, patients with a lot of inflammation have less improvement in symptoms. So we can see here that in BPH, there's a lot of comorbidities, things like obesity and type 2 diabetes, et cetera. And a number of these comorbidities are associated with inflammation. So we have then looked at autoimmune disease as a potential association as well, because patients with autoimmune disease, some subset of these diseases have a lot of systemic inflammation. So we decided to look at our patient cohort at NorthShore, and we went into our patient database and looked at the baseline prevalence of BPH in patients without autoimmune disease. So this turned out to be 20.3%. But if we look at patients with autoimmune disease, this significantly increases to 30.6%. So patients with autoimmune disease have significantly higher diagnosis of BPH. However, if we look at patients who have autoimmune disease diagnosed before their BPH diagnosis, so that timeline is that autoimmune disease comes first prior to BPH diagnosis, we see that the incidence of BPH reduces back toward baseline levels. So this kind of suggests that perhaps the treatment of autoimmune disease has an impact on prostatic hyperplasia. So if we break down this autoimmune disease cohort into patients that were treated with different classes of drugs or patients without medication in the last row, then we have the patients without medication as a reference, and then we look at the two primary classes of treatment for patients with AI diseases, which are methotrexate and TNF-alpha-antagonists. So they have different mechanisms of action, but the TNF-alpha-antagonists, you can see the BPH rate, or the rate of diagnosis, is significantly less than patients without treatment. So in this case, we utilized these data to start to interrogate whether we can see an impact of TNF-alpha antagonists in model systems on BPH or in prostatic, both inflammation and hyperplasia. So then we utilize these mouse models. The first one I'll talk about is the non-obese diabetic, or NOD model, in which we've previously shown that inflammation is associated with hyperplasia in the prostate. So here you can see with the dark blue bars that regions of inflammation have a much higher association with epithelial hyperplasia or stromal expansion. So you can see the overlap between the red and green with these with the inflammatory profile. And then in the white bars, there's still, of course, some hyperplasia in these situations, but it's less than when inflammation is surrounding that region. So we utilize this model to treat these animals with TNF-alpha antagonists, and we use etanercept specifically, doing a twice weekly injection for 5 weeks to look at prostatic phenotype. So when we did this, we could see that there was a significant reduction in epithelial hyperplasia, or proliferation in this case with Ki-67 staining, where we had 12 etanercept treated and 8 control treated animals. And then since our human single cell RNA-seq data, which I'll talk about in a little bit, thanks to our P20 center, I have a circle around the macrophage compartment, and we saw that the macrophages were the cell type in terms of the inflammatory cell compartment, expressed both TNF and the receptor. So they were both TNF producers and responders. So we also looked at the macrophage infiltration in the prostate and NOD mice, and we see a significant reduction again in F480 or macrophage accumulation in etanercept treated versus control mice. So we also utilized an alternative model, just because there is no perfect model of BPH in animals, of course, in mice at least. So we did a TNF-antagonist treatment in probase and prolactin mice, where it's prostate-specific expression of prolactin, and these mice have an increased prostate size or volume as they age. So we worked with the NASTWIC laboratory at Roswell Park, and they use ultrasound to follow prostate volume over time. So in their case, they did a 12-week etanercept treatment, and you can see that over time, we see that etanercept significantly reduces the prostate volume in these animals. As would be expected, we also see a reduction in epithelial proliferation that goes along with the volume data. And then we also wanted to utilize, since we work in a hospital system, we always prefer to translate to human tissues in our studies. So we looked at human patients that we have within our biobank, which I'll talk about as a resource in a little bit. Men treated with TNF-alpha antagonists also have a decreased proliferation and inflammation in their prostate. So again, we were able to identify 5 patients in our biobank that were treated with TNF-alpha antagonists prior to their prostatectomy. So since we have full clinical annotation on our biobank, we were able to go into the clinical records, look for the treated patients, and then compare to age-matched and BMI-matched control patients. So again, we see decreased epithelial proliferation and macrophage infiltration in these men. So I did want to talk about our resources, since we have, since I'm in the resource session here. Our P20 that we had was for isolation of all leukocytes or immune cells that are CD45 positive from both small and large male BPH tissues. So we used, as best we could, we used age-matched and BMI-matched tissues, as you can see in the top left, and then the bottom left, you can see that we selected based on size, so it's not surprising that we have significant difference in size. And then also, of course, the large patients tended to have a higher IPSS prior to surgery. So the large patients have not only a large prostate, but also a high symptom score. So we have our complete data set now, where we have 10 small and 10 large patients, where we have complete profile of all of the infiltrating immune cells. And you can see the profile, the most general profiles here. We are continuously working with both amongst ourselves and with others about defining these subpopulations and understanding the function of these inflammatory compartments, because we believe that they play a significant role in BPH as a disease. And then another resource that we have more recently is single-cell RNA-seq of all cells in BPH tissues, which we can certainly look for overlap with Doug Strand's group, as he just described. But again, you can see that we have a nice representation of all cell types that we can then look for intercellular communication, which is the primary direction that we're going with these data. And then finally, I just wanted to again acknowledge our prostate tissue biorepository, because we now have nearly 1,000 patients who have donated prostate tissue to us. And we have both fixed and frozen tissues from these patients, and both the peripheral and transition zone from the majority of these prostate tissues. And then again, probably the most valuable asset to our biorepository is the full clinical annotation, such that we can, as I showed earlier in my discussion here, that we can go back and select patients based on whether it's drug treatment or comorbidity or any other clinical parameter that would be in their medical record. So with that, I'm going to acknowledge all of the people that have been involved in these studies. The P20 was between NorthShore University Health System and Tim Ratliff's lab at Purdue University, to which Nadia Landman also did a lot of this analysis. And then our funding is listed. So thank you so much.